This is a story of a patient who had 3 options for his lumbar spine. He chose one of them. It was not the one I recommended. And 9 months later, he's back. And I'm about to tell you exactly why. I'm Dr. Tammy Penhollow. I'm a physician specializing in spine and joint care and regenerative medicine. 11 months ago, this patient came to me with 4 things going on simultaneously: cervical spine, lumbar spine, hip, and knee. We talked through everything. We mapped out this comprehensive approach. And when it came to his lumbar spine, where he had an annular tear in a disc directly above a prior fusion, I laid out 3 options. He could pursue a discectomy and extend the fusion surgically. He could look into a procedure called DISCSEEL, which uses a biologic sealant to address the disc itself. Or he could do what I was recommending: treat the lumbar spine as a functional unit. Bone marrow aspirate concentrate to the disc, plus the facet joints, the epidural space, the ligaments, the sacroiliac joints, the surrounding musculature, the whole system. He chose DISCSEEL. I respected that decision. It was absolutely his to make. But before he went, I asked him one thing. Would he be willing to ask the physician performing that procedure whether they could also address the facet joints, the epidural space, the ligaments, and the stabilizing muscles at the same visit? He asked. The answer he got back was that treating all those structures was overkill. Too many needles. That's not how pain management should be practiced. So he had the DISCSEEL procedure 9 months ago. When he came back to see me recently, he still had significant lumbar spine pain. So last week, I took him into my procedure suite and we did what I recommended 11 months ago: the full functional spinal unit. That's what this video is about. I want to be fair to this procedure before I explain why it wasn't enough for this patient. DISCSEEL uses an annular sealant, a biological fibrin-based material, to seal tears in the outer wall of the disc, the annulus fibrosus, which is this tough outer ring of the disc. It can develop tears that allow the inner disc material to press outward and generate significant pain. Sealing those tears is a legitimate clinical goal. The disc is a real pain generator, and discogenic pain is real. Addressing the disc directly is something I advocate for. It's a cornerstone of how I approach lumbar spine care. But the disc does not exist in isolation, and that's where this story becomes a lesson. I've talked about this before on this channel, and I'm going to come back to it because it's the most important concept in spine care, and it's the one that's most consistently ignored in how spine pain is being treated. Your spine is a functional unit. At every level, every single vertebral segment, you have a disc, 2 facet joints, a set of ligaments connecting those structures, and the deep stabilizing muscles that control the segmental movement. Those structures do not operate independently. The disc handles axial load, up, down. The facets guide motion and share load. The ligaments constrain movement at the end of range. Think flexion, extension, side bending, and rotation. The multifidus muscles and the deep stabilizers provide dynamic control of the segment during movement. When one structure in that unit is compromised, the others compensate. When a disc is degenerated or torn, the load shifts to the facets. The facets begin to degenerate and degrade under load they were not designed to carry alone. Then the posterior ligamentous complex takes on more tension. The stabilizing muscles receive altered proprioceptive input and begin to inhibit. And the cascade that results is not a disc problem. It's a system problem. Treating only the disc, regardless of how precisely or effectively that treatment addresses the disc itself, does not interrupt the cascade. The facets are still overloaded. The ligaments are still lax. The stabilizing muscles are still inhibited. That segment is still unstable. And the pain that was attributed entirely to the disc may in fact be coming from several structures simultaneously, structures that were never touched. I want to address the response my patient received directly. When the person performing his DISCSEEL procedure was asked whether they could also treat the surrounding structures, the facet joints, the epidural space, the ligaments, the muscles, the answer was that this was overkill, too many needles, not how pain management should be practiced. And I understand that perspective that comes from a single structure, single procedure model of care. But I want you to hear what that answer actually communicates. It communicates that the spine is a collection of separate parts that can be addressed one at a time. It communicates that treating the disc is sufficient if the disc is the labeled pain generator. It communicates that the comprehensive system level care is excessive rather than thorough. My patient lived the consequences of that philosophy for 9 months. Not because the procedure failed, but because the disc was not the only structure generating his pain. And the structures that were generating the rest of it were never treated. When he came back, I did what I recommended 11 months ago. We treated the lumbar spine as a functional unit, bone marrow aspirate concentrate to the most demanding portion that was not yet treated. Right? We've got the facet joints at the affected levels because they'd been compensating for an unstable disc for over a year and they were symptomatic. We did the facet joints above that and below that. The epidural space to address the inflammatory component that had been building around the affected segment. The ligaments of the posterior complex because ligamentous laxity at that level was contributing to segmental instability. The surrounding musculature, because the deep stabilizers had been inhibited by pain and altered input for long enough that they needed direct support. That is not overkill. That's treating the organ. And this is also why I treated his cervical spine, his hip, and his knee 11 months ago when he first came in, because those were also part of this clinical picture. The kinetic chain from the ground all the way up, and they deserve the same comprehensive approach. The structures we treated then have held. The lumbar spine, the one where a different philosophy was applied, had not. I'm sharing this case because it's not unique. The spine patient who has one procedure or two procedures or a sequence of procedures each aimed at one structure and who still has significant pain is one of the most common presentations I see. Not because procedures were performed poorly, but because the philosophy behind them treated the spine as a collection of parts rather than a functional system. If you're currently navigating the spine care decisions, if you're considering a discectomy, a fusion, an intradiscal procedure, a series of injections, there's one question worth asking before you proceed. Is the physician in front of you thinking about the whole system? Are they talking about the facets, ligaments, stabilizers, metabolic environment, the load distribution across the segment? Or are they focused exclusively on the structure that showed up most prominently on your imaging? Because what shows up most prominently on imaging is not always what's generating the most pain. And treating the image without treating the system is a philosophy that has a very well documented ceiling. Before you agree to any spine procedure, ask whether the treatment plan addresses the functional pain, the functional unit, or just the structure being targeted. And it shouldn't just be, yeah, we're going to send you to PT and yeah, you should eat pretty well. These are not difficult questions, but they're almost never asked. And the patients who ask them get better answers from these physicians who actually get it. If you pursue this comprehensive treatment of the spine as a functional unit, the disc is addressed with the most durable biological tool available for a structure with almost no blood supply. The facets, ligaments, and stabilizers are treated simultaneously, so the cascade is interrupted rather than managed one piece at a time. You're not back in 9 months because a structure adjacent to the treated disc was never addressed. If you pursue single structure treatment of a system problem, the disc may be treated effectively while the structures compensating for it continue to degrade. The pain that was attributed to the disc may persist because it was never entirely discogenic to begin with. The segment remains unstable because the unstabilized muscles, the systems were never part of the plan. And with the conversation about what to do next begins again, with fewer options than before and a more complicated biological environment to work with. For some people, understanding this is enough to start making better decisions. For others, they want structure, sequencing, and accountability. If that's you, there are 2 ways I work with people. A guided system designed to help you start improving knee pain step by step, or a more intensive, personalized approach where we work together more closely. Those options are in the description if and when you're ready. I've also put together a free resource called The Patient Guide to Ethical Regenerative Medicine if you want a clear framework before making any decisions. And if not, keep learning. That's always a good next step.